Hello, welcome to Anatomy DAHAR series. Today's topic is about the larynx. Blood supply, nerve supply, lymphatic drainage and nerve lesions of the larynx. Illustrated and presented by Dr. Abdul Hamid, Abdul Rashid. Blood supply of the larynx. This is a diagram of larynx, anterior view. As you know, the larynx consists of three compartments: upper or vestibular compartment, middle or ventricular compartment, and lower or infraglottic compartment. So let's talk about the arterial supply. The upper part of the larynx, that is the vestibular compartment, is supplied by superior laryngeal artery, which is a branch of superior thyroid artery which comes from the external carotid artery. It enters by piercing through the thyrohyoid membrane together and below the internal laryngeal nerve. The lower part, that is the ventricular and infraglottic part of the larynx, that is below the vocal folds, are supplied by inferior laryngeal artery, which is a branch of inferior thyroid artery, that is the branch coming from the thyrocervical trunk of the subclavian artery. It accompanies the recurrent laryngeal nerve. Blood supply of the larynx continuation. Anterior view of the larynx. This is internal jugular vein, left internal jugular vein. This is left brachiocephalic veins. Venous drainage of the larynx. Superior and inferior laryngeal veins drain the superior and inferior parts of the larynx and open into the superior and inferior thyroid veins respectively. Superior thyroid vein drains into the internal jugular vein or common facial vein. Inferior thyroid vein drains into the internal jugular vein or left brachiocephalic vein. This is lateral lobes of the thyroid gland, and this is isthmus of the thyroid gland. This is inferior thyroid vein. It is located anterior to the isthmus of the thyroid gland. In tracheostomy, a hole is made through second and third tracheal rings. It often required to divide the isthmus of the thyroid gland. If so, need to ligate the inferior thyroid vein. Lymphatic drainage of the larynx. This is the very simple schematic diagram of the neck seen from right anterolateral side. This is upper deep cervical nodes, also called jugulodigastric nodes, and this is lower deep cervical of the nodes, that is jugulo-omohyoid lymph nodes. Now, lymphatic from the upper part of the larynx, that is vestibular, that is also called supraglottic compartment of the larynx, pierces through the thyrohyoid membrane, that is the membrane between the thyroid cartilage and hyoid bone, and drains into upper deep cervical, that is jugulodigastric nodes, also called Robin's level 2. Lymphatic from the lower part, that is the ventricular and infraglottic compartments, below the vocal folds, pierce through the cricothyroid membrane, that is the membrane between the cricoid cartilage and thyroid cartilage, and drains into the prepharyngeal and pretracheal lymph nodes. They are in front of the pharynx and trachea, also called Robin's level 6, then drain into the lower deep cervical nodes, that is jugulo-omohyoid nodes, Robin's level 4. The vocal cords themselves act as a barrier separating the two lymphatic areas, but posteriorly there is a free communication between them. Therefore, laryngeal carcinoma may thus spread throughout the lymphatic drainage area of the larynx. Nerve supply of the larynx. Let's see two diagrams here, A and B. A is showing the lower part of the brainstem. This is pons and this is medulla. Medulla consists of huge nucleus called nucleus ambiguous. In this nucleus, we have three nuclei are there. The top one is ninth cranial nerve, that is glossopharyngeal nerve nucleus. The middle one is 10th nucleus, that is the vagus nucleus. And the third one, the lowest one, is 11th cranial nerve nucleus, that is cranial accessory nucleus. If you see the diagram, the vagus nucleus will give vagus nerve fibers, blue color, coming down along the neck. And at the same time, cranial accessory, that is 11th cranial nerve nucleus, also give fibers coming down together with the vagus nerve. And this cranial accessory nerve fibers will give two branches here in the neck, superior laryngeal and recurrent laryngeal nerve fibers. They are coming from the cranial accessory nucleus, from the nucleus ambiguous. Now we'll continue nerve supply of the larynx. Based on the developmental anatomy, laryngeal cartilages and all the intrinsic muscles of the larynx are derivatives of 4th and 6th pharyngeal arches. The nerve of these arches arises from the cranial part of the accessory 11th nucleus. It is located in the nucleus ambiguous of the medulla, A, I have already mentioned. Therefore, fibers of the cranial accessory nucleus supply the intrinsic muscle of the larynx, not the vagus. The cranial accessory nerve fibers follows or come along the vagus nerve. So you can see in this diagram very clearly mentioned here. So although it is stated that the intrinsic muscles of the larynx are supplied by the branches of the vagus, actually they are fibers of the cranial accessory nerve which comes along with the vagus nerve. Continuation, the cranial part of accessory nerve which comes along with the vagus nerve gives two branches. Look here, this is cranial accessory, green color, coming along with the vagus. This gives two branches in the neck. The upper one is called superior laryngeal nerve and the lower one is called recurrent laryngeal nerve. Superior laryngeal nerve again subdivided into two branches. The one here is called external laryngeal nerve and this one is called internal laryngeal nerve, which pierces through the thyrohyoid membrane and enter into the larynx. Continuation, the recurrent laryngeal nerve, RL, is located behind the cricothyroid joint and enters under the inferior constrictor muscles. Motor supply, all the intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve, except the cricothyroid muscles, this is the one, which is supplied by the external laryngeal nerve. So, all the intrinsic muscles of the larynx are supplied by fibers coming from the cranial accessory nerve, which came along with the vagus nerve. Let's see the diagram again. This is recurrent laryngeal nerve. This is superior laryngeal nerve, which divides into external laryngeal, which supply the cricothyroid muscles, and into internal laryngeal nerve, which goes through the thyrohyoid membrane and enters into the larynx. Now we are going to talk about the sensory supply of the larynx. Part of the larynx above the vocal fold, that is vestibular compartments, and up to the most posterior part of the tongue are supplied by the internal laryngeal nerve, which is the branch of superior laryngeal nerve. That means sensory above the vocal fold of the larynx. Next is the vocal folds, and part below that is infraglottic compartments are supplied by recurrent laryngeal nerve. That is for sensory. So recurrent laryngeal nerve will supply all the intrinsic muscles of the larynx, motor, except this cricothyroid muscles, and recurrent laryngeal nerve will supply sensory of the larynx below the vocal cords. Sympathetic. It is vasoconstrictor that comes along the superior and inferior laryngeal arteries, which come from the middle and inferior cervical sympathetic ganglia. Look at the diagram, anterior view of the larynx. This is lateral lobes of the thyroid, and this is isthmus of the thyroid. Upper part of the thyroid glands receive arterial supply from superior thyroid artery, and lower part receives arterial supply from the inferior thyroid artery. Superior thyroid artery is closely related to the external laryngeal nerve, and inferior thyroid artery is closely related to the recurrent laryngeal nerve. We have already mentioned that external laryngeal nerve will supply the cricothyroid muscles, and recurrent laryngeal nerve will supply all the intrinsic muscles of the larynx except cricothyroid muscles. External laryngeal nerve is closely related to the superior thyroid artery, and recurrent laryngeal nerve is closely related to the inferior thyroid artery. Therefore, in thyroid operations, bronchial or esophageal carcinoma, malignant involvement of the deep cervical lymph nodes, secondary metastatic deposits, and mediastinal lymph nodes, these nerves are very much likely to be injured. So when there is loss of voice, you must be very careful and investigate very thoroughly. Positions of the vocal cords in normal and in nerve lesions. We are looking from above through the laryngoscope. This is in front, anterior. This is posterior. In the case of normal, if you see from above, you can see here, epiglottic is here. Behind is, you can see a pair of vestibular folds at the higher level, we have already mentioned, and much wider. Below that is the vocal cord, vocal fold is there, which is below this vestibular fold and much narrower. That's why you can see both pairs through the laryngoscope. Now this diagram is many plane there. You can see abnormal locations of the vocal cords are there. Look here, this is M is in the median plane, PM is paramedian plane, and C is cadaveric plane, and the normal, this normal will be around here, and after that MAB is moderate abduction, and FAB is full abduction stages there. They are abnormal positions. First is injury to the external laryngeal nerve. We are going to talk. This is external laryngeal nerve. It supplies the cricothyroid muscles. When this nerve is injured, cricothyroid muscles become paralyzed. Its function is to tense the vocal cords. So once this muscle is paralyzed, the vocal cord on that side cannot be tense, become lax. It produces weakness of the voice. Next is injury to the recurrent laryngeal nerve. It has many types. Only one side of the recurrent laryngeal nerve may injure, or both recurrent laryngeal nerve may injure. Even in each type, injury may be complete or partial. So let's talk about this injury. First is unilateral complete injury of the recurrent laryngeal nerve. In that case, all the intrinsic muscles on that side except cricothyroid muscle will become paralyzed. So all the muscles, especially adductor and abductor, will be paralyzed. So the positions of the vocal cord, vocal fold, will be in neutral position, that is paramedian position between the abduction and adduction. So the vocal fold and vocal cord will be just lateral to the midline. The speech is not greatly affected because the other vocal fold will compensate for some extent. Number 2, unilateral partial injury of the recurrent laryngeal nerve. In this type of injury, there is a greater degree of paralysis of the abductor muscles than that of the adductor muscles. Why? It could be assumed that the abductor muscles received greater numbers of nerve fibers than the adductor muscles, and therefore more fibers of the abductor muscles are paralyzed, and some adductor muscle fibers still remain intact. The vocal fold on the affected side is thus adducted and positioned at the midline. Here. From here, move to the midline on that side. This is known as Simon's law. So, unilateral partial injury is more severe than unilateral complete injury. Number 3 is bilateral complete injury of the recurrent laryngeal nerves. That means both recurrent laryngeal nerves are completely injured. What will happen is, that means all the intrinsic muscles of the larynx supplied by the laryngeal nerves will be paralyzed, but cricothyroid muscle, which is supplied by the external laryngeal nerve, will be escaped. In this case, because abductor and adductor muscles are paralyzed, so there is abduction and adductions are lost, so the vocal cord will be midway between abduction and adduction. Breathing is impaired because rima glottis is partially closed, nearer here, partially closed, and become narrow. Therefore, speech is lost. Next is number 4, bilateral partial injury of the recurrent laryngeal nerves. It is very similar to unilateral partial injury, but this time both sides. In unilateral partial injury, we have already discussed that abductor muscles are affected more. Adductor muscle fibers, some remain intact. So what happened is, in this case, both adductor muscles are still intact, so it will draw the vocal cords towards the midline, both sides, because adductor muscles are still, some fibers are still intact, so they will bring the vocal cord, both right and left side, to the midline. Acute breathlessness, dyspnea, and stridor may follow. Cricothyrectomy or tracheostomy is necessary. Therefore, bilateral partial is more severe than complete injury. Lesions of the laryngeal nerves. External laryngeal nerve. Paralysis of cricothyroid muscle. The vocal fold cannot be tense. It is lax on the affected sides. It produces weakness of the voice. Second is recurrent laryngeal nerve injury. We have many types here. One side complete, one side partial injury, both side complete or both side partial injury. The first one is unilateral complete. Vocal cord is in neutral, that is paramedian position on the affected side, just lateral to the midline. Speech is not greatly affected. Second type is unilateral partial injury. Affected vocal cord is at midline. Great degree of paralysis of the abductor muscles, called Simon's law. The third type is bilateral, both nerves, complete injury. Both cords at midway between the abduction and adduction. Breathing is impaired. Speech is lost. Next is bilateral, both sides, partial injury. Both cords are drawn to the midline because greater loss of abductor muscle. Acute breathlessness, dyspnea, followed by stridor. Note, partial injuries are more severe than complete injuries. Emergency access to the airway. Let's see the diagram first. This is right lateral view of the larynx and part of the trachea. This is cricoid cartilage. This is thyroid cartilage. Between these two is cricothyroid membrane. This is second and third tracheal rings. In front, we have isthmus of the thyroid gland. Let's talk about the emergency access to the airway. Two common methods here. A, cricothyrectomy. That is a very quick and relatively easy method. Just make a small hole through the cricothyroid membrane here, which is between the cricoid cartilage and thyroid cartilage, just to establish a patent airway. It is a life-saving. Anesthetic is not essential. Second method is formal tracheostomy, that is going through the trachea. You can see here, this is second and third tracheal rings. Not usually an emergency. Need full anesthetic, ideal for temporary or permanent intubation. A hole is made through second and third tracheal rings. It often needs to divide the isthmus of the thyroid gland, which lies in front of the second and third tracheal rings. If so, as I have stated earlier in venous drainage of the larynx, you know inferior thyroid vein will be in front of the isthmus. You might have to ligate it. The end, illustrated and presented by Dr. Abdul Hamid Abdul Rashid. Now is a good time to subscribe to our Anatomy DAHAR series channel. You will be notified as soon as our next video is available to you. Anatomy DAHAR series also provides other videos related to the present topic. Enjoy and thanks for watching.